So let's get started. Yeah. So lovely. So we are going to definitely make inroads and make up little bit for whatever we could not do well yesterday, right? Okay, great. So starting with the message that together we can. So thank you everyone for sharing your suggestions to improve the class, right? So out of all the suggestions, there were two important problems that I noticed were recurrent. Okay, so I'm sure majority of you are facing. Trust me, each student, each one of you is my responsibility. I want to make sure that each one of you goes home happy, satisfied, and with full knowledge of rheumatology, right? So two important things, yes, two important things that we have. One problem which was consistent across many students is that because of the PPT and not writing together with you, it happens that students cannot read, write and listen together. That was one of the important problems that we were having to see, right? And so solution that I have found for now, because till now I'm not able to get a writing pad, so I will have to make do with this suggestion, right? So the suggestion today will be that I'm going to make the sentences appear one at a time. Okay, so they will be slow. I will read the sentences. I'm going to write it parallelly so that I give you the same amount of time to take down the notes and we are able to discuss as well as understand, right? So this is the closest to me writing that I can take you all. So first problem we will solve by going slow, right? So we'll go slow one by one and you will be able to get. Yes, Ramdev, that problem will be solved today. Don't worry. The second problem I noticed that, see, because of the live streaming, there is a 30-second lag from the time that I am speaking and the time that it is relayed to you. So what is happening is that when I see your doubts in the chat box, I may have already gone 30 seconds ahead and maybe to a next topic. So my answers to your doubt is coming in between the topic, and to avoid that, what I'm going to do is I'm going to note down all your doubts from the chat box one by one, and I'm going to answer them at the end of the topic together, right? Before we call it a day. So we'll all go one by one, right? So let us go ahead. Right. So thank you, sir, everybody, for understanding. So let's make it count. There is no absolute reason that we cannot make it work, and we'll do it great. Chalo. Right. So let's start with a small recap. So simple, this is a recap of what we did yesterday. Let us start with that recap of yesterday, right? So first point, what we ended yesterday, we studied yesterday the physiology of immune system. We learned what is autoimmune disease. We learned the mechanisms of autoimmune disease, and we also classified what are the rheumatology conditions, right? So the rheumatology conditions. So first point, I'm going to bring it one by one. Let's understand. Rheumatology, when are we going to suspect? It is suspected in cases with unexplained fever. So we made this point yesterday that when there is a patient with unexplained fever having common test of infection negative, we suspect autoimmune disease. And if the autoimmune disease has multi-organ involvement, we are going to suspect rheumatology disease. That's number one. Number two, what did we do? If we have a patient, so start thinking in the clinical realm, start thinking clinical medicine. If you encounter, if you have a patient like this in your clinic who has come with a suspected rheumatology disease, we want to classify the disorders into three broad categories. Yesterday we saw three broad categories, of which based on one characteristic feature if it is present. So everybody, we saw number one, if the patient has got a lupus, that is wolf bite like skin rash is present. If there is a wolf bite like skin rash is present, we are going to classify that the patient is suffering from lupus disease. That is number one. Second group, we said if the patient with suspected rheumatology disease has a joint deformity, then you will suspect that he or she may be suffering from arthritis group of disease. And third point, if the patient has a purpuric skin rash, then we are going to suspect vasculitis group of disease. That's what we are going to go for. Okay, so simple classification. So I'm starting with that recap and then we take it forward to today's class. So based on characteristic feature, if it is present, you can predict what is the probable group of the disease. Even if the features are not present, we can take the help of the most sensitive, most common, that is the screening antibody. So we can see that we can look at the sensitive and the screening antibody that we have. So in the screening antibody, one, if the patient has got ANA positive, if the patient is ANA positive, he or she is likely to have, we will classify them as lupus group of disease. If RA factor is positive, we will call them as arthritis group of disease. And if ANCA is positive, we are going to classify them as vasculitis group of disease. Okay, so first take it here. So all my handmade notes, I'm going to post some relevant pages on the Facebook club after today's class along with the doubt thread. So just be with me. We'll make sure we can understand it well. So we classified rheumatology disease into three broad categories based on one, the characteristic feature present, and number two, based on the sensitive antibody present. Now within the group, how should we proceed further? Within the group, focus first group. Everybody focus on the first group. In lupus group of disease, what we are to see further? Within the lupus disease. So suppose a patient is having in the rheumatology clinic ANA positive. You think it is a lupus disease. But within the lupus, it is you are to look for the specific feature and the antibody present. Please remember this. We are going to learn more about this today. So based on the specific feature and antibody present, we have got three individual diseases to discuss. We want to discuss SLE, scleroderma, also called systemic sclerosis, Sjogren's and Sicca syndrome. We want to discuss. Under, okay, second slide, below the arthritis group of disease, we are going to focus on the pattern of joint involvement. So every patient, after giving them a group, we have to further divide them into the final diagnosis. So based on the pattern of joint involvement, we have got again three diseases to discuss under arthritis group of disease. Most famous is rheumatoid arthritis, the spondyloarthropathies and crystal induced arthropathies. So this we have written yesterday in the table. Today I am just doing a recap of the index that we have made yesterday. Right? Now, so last point, within the vasculitis group of disease. Vasculitis group of disease, we are going to classify them further based on the size of the vessel predominantly affected. So whether it is large vessel vasculitis, medium vessel vasculitis or small vessel vasculitis, that's how we are going to classify and discuss individual disorders. So yesterday we said in rheumatology, we are going to discuss one, lupus group of disease, two, arthritis group of disease, three, vasculitis group of disease. Additionally, you can see the purple pen here. You can see the purple pen here. So if the patient happens to have both ANA also and RA factor also, if the patient has got both screening antibody positive, then what do? It becomes a problem. When the patient has both it as positive, then we are going to call it as overlap syndrome. Okay, so we are going to call this as overlap syndrome. So overlap syndrome is basically when clinical features are also mixing and both antibodies are also present, we group them as overlap syndrome. So one is the MCTD, yesterday we saw mixed connective tissue disorder and lupus. So this is basically the summary of what we have reached yesterday. So we did first physiology, we understood autoimmune disease, mechanisms, presumptive diagnosis and classification of rheumatology. thanks to Harrison, what we have also added now to rheumatology is the myositis group of disease. So according to new edition, we are also going to discuss under rheumatology the myositis group of disease. So polymyositis, dermatomyositis, inclusion body myositis. We are also going to write it down. Okay, so these are the points step by step. These are the diseases groups which constitute rheumatology. So every time I always tell the students that when you sit to study, please make sure to know what is your objective or what is your target. It is very important to plan what we are going to read in the coming few hours. So yesterday we did a basic introduction to rheumatology. Today we are going to start with the individual groups of disease, right? So recall from yesterday, we did the physiology of immune system. We have classified the disorders. The disease, the classified, the disorders also we have done. So what comes next? Before we reach the individual disease, like SLE and all, what we want to do is discuss antibody testing. That's what we want to do. So, what is this antibody testing and why is it important to us? Please understand, why is antibody testing important to us? So, the common approach to diagnosing all rheumatology disease is this. So, whenever you are sitting in a rheumatology clinic and you have a patient, first thing what you have to do, clinically suspect which group and which is the probable disease. So first thing, based on the clinical features having in the patient, you suspect which group and which disease patient is suffering from. But along with this, only clinical feature does not confirm diagnosis. You have to go for the second step. That is, you have to go for the screening antibody. Yes, you don't have to draw the arrow, but I want you to write just a points. Clinical suspicion followed by screening antibody testing, and finally you confirm diagnosis using the specific antibody. So rheumatology is a very simple high yield topic. Most medical college students do not know much about rheumatology. They feel it is super specialty stuff. But trust me, it is not. Rather, it is just a fellowship stuff. It's not even you need an MD. You just need MBBS and a fellowship and you will be good rheumatologist to do. So clear the approach. Clinical suspicion based on the features. We must know screening antibody we saw in the index, and we have to learn yet the specific antibodies along with every individual disease. That's what we want to see. Right. So next time. So before we go to the antibody test, so we want to look at antibody test. I want you to know there are the difference between autoimmunity, autoimmune disease. I want you to write this down. I want you to know the difference between autoimmunity and autoimmune disease. I want you to know the difference between autoimmunity, as you can see, it is in green, and difference from autoimmune disease, which is in red, which is the disease. That's what I want you to understand here. So what is this autoimmunity? This is the first line in Harrison also, first paragraph of rheumatology. This has been clarified. So first point, what is autoimmunity? Autoimmunity is just presence of autoantibody. Autoimmunity is just presence of autoantibody in the blood of the patient. So there is just autoantibody present does not mean he or she is having a disease, because how does this antibody develop? Chances of developing autoantibody increases with age, multiple pregnancy, etc. So there are environmental factors. Each day we are exposed to pollution, exposed to toxin, we are aging, and there can be development of autoantibodies, right? So they can see the autoantibody can be present in normal population also. especially in elderly and in females. Especially in elderly and in females, presence of autoantibody is not uncommon. Remember that word. So hence we say it is common in females. So we all know, as a thumb rule, autoimmune diseases are more common in the females. So this is the probable reason. Come to the other side. So first point is clear, that autoimmunity can be there, but that does not mean there is disease. So what do you mean? Other side of the table, the red part. What is autoimmune disease then? What is autoimmune disease? Autoimmune disease means the presence of autoantibodies in significant titer enough to cause target organ damage. Autoimmune disease means there is presence of autoantibodies in significant titer enough to cause target organ damage. So I can give you analogy to help you understand. So when each of us, if you measure the blood pressure, is our blood pressure zero? Answer, no. We all have a blood pressure. But does that mean we are suffering from hypertension? No. Please focus on this definition. What is hypertension? Hypertension is any increase in the blood pressure which is enough to cause target organ damage. Same analogy goes with diabetes also. Our blood sugar level is not zero, but when the blood sugar level is more enough to cause target organ damage, we call it as a disease condition. So same way, we want to know autoimmunity can be physiological phenomena. But autoimmune disease is what we are here to discuss today. Rheumatology is about autoimmune disease, not just antibody. So tomorrow, if you just do a routine test and you do ANA testing, because nowadays lot of health packages include ANA as a part of screening. So suppose your ANA test comes positive. Does that mean you have to start on steroids? Answer is no. Just having ANA positive means you have autoimmunity. You are predisposed. You are at a risk of developing autoimmune disease is correct. You are at a risk. But when do you need treatment? Only when you have got organ involvement. So unless and otherwise antibody causes harm to our organs, we do not need to evaluate, do not need to treat further. Okay, I hope this is clear. Right? So this is our first step to know. We want to start antibody testing. So we have understood the meaning autoimmunity, autoimmune disease. Right? Next step, please. So in the next step, we will see here. Right. So next step we will see. So as I told you, I am noting all the doubts that are coming in the chat box. I am noting all the doubts and I will answer it at the end of this topic. Okay. So don't worry. I am listening. I am noting down your doubts also. Okay. So first question, what is the best screening test in autoimmune disease? So question is what? What is the best test, screening test in autoimmune disease we want to know. Okay, one by one. So in autoimmune disease, please note the point. I am not saying rheumatology. I am using the word autoimmune disease. I am asking. So in autoimmune disease, you want to start with ANA testing. So you want to start with the ANA testing. That's what we want to do. So as I told you yesterday, if you recap, in a patient who has come to the clinic with recurrent unexplained fever, what we said, PUO, infections are negative, then you think of autoimmune disease. And in autoimmune disease, the first test, if you suspect autoimmune disease, you must ask for ANA testing, anti-nuclear antibody testing. So why ANA testing? Please note down, because it has got 98% sensitivity. ANA testing because it has got 98% sensitivity, and that is why it is the best screening test for autoimmune disease, because it has got 98% sensitivity. Now, there are two methods. There are two methods of doing ANA testing. So what are these two methods of doing ANA testing? We need to know. So you have to write all this. Yes, because these are all part of our investigation assessment method. So you have to write it. These are just points that we need to note down. So which are the two methods? A, number one method, which is commonly available, commonly done, is the ELISA method. So I'm hoping the pace is fine with you today. We will go step by step. So we have got A is the ELISA method. A is the ELISA method. Number one method that we can do. So ELISA method is qualitative only. So what is the limitation of this method? We must see. So we must see why it is the first method and what are the limitations that of the method. So it is qualitative only. Qualitative means what? That the result of the test is only going to tell you whether the blood is positive for ANA or not. That's all. It's going to tell in the given sample whether the ANA is positive or not. That's what we want to know. Okay. Next one. So hence it may be false positive. How do you know that it may be false positive? So how do you know that it may be false positive? Because what we studied on the previous page, autoimmunity. So in an elderly patient, in a female, it can be positive, but in a small titer. But that ELISA cannot identify, because ELISA is going to tell you only whether the test is positive or negative. It cannot tell you how much is the concentration of ANA in the serum. And that is why it can be false positive also. As I told you, autoimmunity also, it will be positive. In autoimmunity also, ANA by ELISA may be positive. That's why it may be false positive, we can say. Right? Further, however, why do we do it then? If it is not so ideal, why do we do it? We do it because it is cheap. Okay. Please remember, in India, economics is more important than science. I'm sure all over the world, but definitely in our country. Okay. We always think with our pocket, not with our head. Okay. So it has to be cheaper. Along with being cheap, it also must be easily available. Along with being cheap, it is also easily available, because India has got a wide spectrum. Okay, metropolitan cities are few, others are still tier B and towns and villages where availability remains a problem, right? So we want to know easily available. And what is important? It has equal sensitivity. Okay, as I'm coming to each line, I'll point out it is got equal sensitivity to exclude the presence of autoimmune disease. So when I suspect that the patient might have an autoimmune disease and I do ANA by ELISA and the test comes negative, that means definitely ANA is not there. So I can say with reasonable authority that patient does not have autoimmune disease. As a general rule, I can say that. So it is important to know what are the methods and what is the use of which method. Okay. So what additional point will you write? You will write the point that when to do ELISA method, you will hear it in conferences. ELISA method is to be done by a general physician to exclude the disease. Main role of ELISA method is exclusion, not confirmation, because it cannot confirm. Even if ELISA is positive, remember it may be false positive. So what do you do? If it is negative, very good. But what if it is positive? What if it is positive? We want to know. If it is positive, then we want to go for number B, immunofluorescence method. So ELISA is positive does not mean anything. That is what is done in a general package. But if it is positive and you want to investigate further, you want to perform immunofluorescence method. That's our second method. So what is this immunofluorescence method? What advantage does that offer you? What advantage is it offering? Number one advantage, immunofluorescence method is quantitative. Immunofluorescence method is quantitative. Quantitative means what? It can tell you the presence of titers. So what does it do? Quantitative means it gives antibody titers. So it tells you how much is the antibody concentration in the plasma. Because what did we say? When do you call it autoimmune disease? When antibody titers are present in significant titers. So that significant titer we will know only if you perform immunofluorescence method. Only if you perform immunofluorescence method. So in ANA, what is the cutoff? MCQ, what is the cutoff? For ANA, titers more than 1 is to 160. Remember, titers more than 1 is to 160 are considered significant. Titers more than 1 is to 160 are considered significant, and this patient needs further evaluation. It does not tell you which disease, it only tells you problem is there, investigate further. It's a screening antibody. Please remember that it's a screening antibody. So what is this? Why this cutoff? Because as we discussed, lower titers may be found in around 20% of normal population, right? So titers, as I told you, in elderly population, in female population, there may be ANA positive in low titer if they do not have disease. Okay, so many females may be ANA positive, does not mean they have disease, because actually the presence may be low titers of ANA which are not enough to cause disease, not enough to cause organ injury. That's what we must understand. So the two methods, one, ELISA method is the screening. If screening is positive, to see whether it is true positive, we want to do immunofluorescence method. But again, let's take it further. Even if suppose, let us say, immunofluorescence method comes positive in significant titer. Please remember, immunofluorescence ANA comes positive in significant titer. What does it tell you? Remember the line. Let us clarify. Okay, if ANA is positive, recall. What did we say in the classification of lupus disease? ANA can be positive in the lupus group of disease. It can be positive in the lupus group of disease. So ANA positive does not tell you which disease. It only tells you group of disease. So as I told you, ANA can be positive in other organ specific autoimmune disease also. That's why we are not talking only about rheumatology. So one of your questions was that why not RA factor, why not ANCA? Because that is not common. In all autoimmune disease, whether rheumatology or organ specific, the most common antibody is ANA. That's why we do ANA as the single best screening test. Only if other features are present, for example, patient has deformity, then you do RA factor. Patient has rash, then you do ANCA. Otherwise, it is not usually routinely done. That is one answer that I have given to you. Okay, so we do ANA only for screening of autoimmune disease, but ANA positive only tells you patient has lupus disease. It only tells you patient is suffering from lupus disease, right? Lupus disease, it can be telling. So immunofluorescence patterns will help. So what we want to do, if the immunofluorescence is positive in significant titer, we want to also pay attention to the pattern of immunofluorescence. We want to look at the pattern of immunofluorescence, which gives you probable diagnosis. Please note down this table. Note down this table, please. So draw the table with me. We will draw the table together, right? So one, we are going to make the table 3 columns. I want first column for immunofluorescence pattern, second column for probable antibody, and third column for probable diagnosis, right? So what we want to look for, so immunofluorescence pattern you want to pay attention to, which can tell you which is the probable antibody, which in turn can tell you probable diagnosis. Yes, so ready with the table here? So I want you to write step by step. So ANA you will do. So ANA, suppose it has come positive, titers are significant, and you get homogeneous pattern. Note it down, please. Let us write together. If you get homogeneous pattern, so along with the patient having significant ANA titer, the pattern is homogeneous pattern. In homogeneous pattern, it is likely that the patient is having anti-dsDNA or anti-histone antibody. It is a big chart which is given, but I have simplified it just for what is required to us. So don't get disturbed by any controversy. We have simplified the chart for practical and clinical use. So homogeneous pattern is there. That means the patient is likely to have anti-dsDNA, that is double-stranded DNA. dsDNA is double-stranded DNA, or patient is having anti-histone antibody. So one of the two, which we are going to learn now, is a common in SLE. These two antibodies are specific for SLE. They are specific for SLE. Please remember, homogeneous is a pattern. I'm going to show you the images. Homogeneous is a pattern. How the staining occurs. Immunofluorescence is a staining procedure. So I'm going to show you the images. So under the microscope, if you start seeing homogeneous pattern with significant titer, patient is likely to have SLE. But you have to correlate with clinical feature and other antibody testing also. That's how we want to proceed. So one, there is homogeneous pattern. Next one, so centromere pattern is there. Then it is probable antibody is anti-centromere antibody, and the probable diagnosis is limited systemic sclerosis, which is also called CREST syndrome. Okay, so we have got centromere pattern. Centromere pattern is having correlation with anti-centromere antibody, which correlates with the limited systemic sclerosis, which is also called CREST syndrome. Right? So this is what we want to understand. So we are going to get this centromere pattern second. Third pattern we have got is the nucleolar pattern. Okay. In nucleolar pattern, if it is positive, probable antibody, read it carefully, is anti-topoisomerase 1. Nucleolar pattern correlates with the probable antibody anti-topoisomerase 1 antibody. But in your clinical practice, you will never see report saying anti-topoisomerase, because the commercial name is SCL70. The commercial name for the test is SCL70. So if you get ANA positive in significant titers and there is nucleolar pattern, then means it is probably anti-topoisomerase 1 antibody, and the probable diagnosis will be diffuse systemic sclerosis. Please remember, today I'm making it fine tuned. I'm making it very, very focused on the lupus group of disease to start with. Okay. Next one is the speckled pattern. For MCQ, among the four, most common pattern seen in practice is the speckled pattern. Speckled pattern can be seen with both anti-Rho anti-La antibody, which is now called as SSA or SSB. Okay, I'm going very slow. Let us look at it very carefully. Slow. Anti-Rho anti-La antibody. So it is now called as SSA and SSB. What is full form of SS? Sicca syndrome. Full form of SS is Sicca syndrome. Anti-Rho, Anti-La are all old names. The new name is SSA, SSB. But speckled pattern can also indicate presence of anti-U1 RNP. Speckled can also indicate presence of anti-U1 RNP antibody. So U1 RNP antibody may be present. So what is our diagnosis? It could be Sicca syndrome. SS means Sicca syndrome. And U1 RNP is specific for mixed connective tissue disorder. As one of you rightly pointed out, that in overlap syndrome also ANA can be positive. Please remember, there are many people asking one question: have I written in lupus group only ANA is positive? In rheumatoid arthritis, ANA should not be positive. Vasculitis, ANA should not be positive. If in RA, ANA is positive, then it is no longer RA. It will become overlap syndrome. It will become overlap syndrome. Okay. So please remember, we want to focus on first antibody that we are learning. And as we go along, you will understand it better. So again, let's recap. What we know, if patient comes to me, especially young female with unexplained fever, I suspect autoimmune disease. If I suspect autoimmune disease, I am going to start with ANA by ELISA because it is cheap. ANA comes positive, I can go for immunofluorescence method. So why not directly immunofluorescence? Because it is expensive. Please remember, ELISA cost only 250 rupees while immunofluorescence is costing 1800 rupees. So we cannot do it routinely. Only if the screening is positive, you can go for immunofluorescence method. So there are two advantages of immunofluorescence method. One advantage, it confirmed whether it is present in significant titer. It told you whether it is present in significant titer. And number two advantage, as you have seen here, in immunofluorescence pattern also you can see, which can help you make the probable diagnosis. It can also tell you probable diagnosis can be seen. MCTD is mixed connective tissue disorder. Mixed connective tissue disorder is going on. Okay, so let us take it further. So ANA by immunofluorescence pattern, just for you to have a visual picture. Just to have a visual picture that you want to see. So homogeneous pattern, speckled pattern, nucleolar pattern, centromere pattern. These are the four common patterns of ANA by immunofluorescence that we want to see. Okay, so first have a look that how they must be. Homogeneous means immunofluorescence is staining the cell uniformly. Speckled means the cell is staining salt and pepper. Nucleolar, like a bifid nucleus. Nucleolar is like a bifid nucleus. And centromere, like a spindle pattern. Okay, centromere is like a spindle pattern is what we want to see. Okay, so look at them one by one. So what are we going to see? If the immunofluorescence shows homogeneous pattern. Immunofluorescence shows homogeneous pattern. Look at it carefully. If you get immunofluorescence in significant titer and homogeneous pattern, then we are going to suspect it is SLE. we are going to suspect that it is SLE. That's what we are going to look for. Suspect that it is SLE. So rim pattern also can be seen in dsDNA, but important common pattern in SLE, MCQ, most common pattern in SLE is the homogeneous pattern. Is the homogeneous pattern we want to see. Right? Next is centromere pattern. Next is centromere pattern. I am writing it in the same order for you to remember it better. Centromere, if you can look, there are a small spindle shape. You have to just visualize based on the picture I have given you for reference. It is correlating with anti-centromere antibody. So probable diagnosis is CREST syndrome, also called as limited systemic sclerosis. CREST syndrome, also called as limited systemic sclerosis, we want to see. Further, when you get nucleolar pattern, already I have written this. All these images are available in your eMedicos app under images, class images rheumatology. It is already uploaded. Okay, part of the lecture I am keeping it so you can correlate. Nucleolar pattern, if you see like a double nucleus, nucleolar staining, if you see, then the probable diagnosis becomes diffuse systemic sclerosis. SSC, I have written the full form. Systemic sclerosis is another name for scleroderma. Scleroderma we want to see. Okay, you can look in the app under images if you want to zoom it and look at it closely. Speckled pattern, if it is seen, salt and pepper appearance, speckled pattern, it can be that the diagnosis is probably Sicca syndrome or MCTD. Sicca syndrome or MCTD, we can correlate. So what is the point here I have made? That we want to understand importance of these testing. So each test has its own value. So first step, as I told you, what is the thing? So we reviewed physiology of the immune system. We did the classification of the disorders today, and we also discussed the antibody testing, especially screening antibody for all autoimmune disease. So now we are ready to start with the individual disorders. So you must understand first that how it is. Okay, all are looking same, bolne walo. Ana, just remember this always. In pathology, in anatomy, as an MBBS student, आपको माइक्रोस्कोप के नीचे क्या दिखा, है ना? Most of us, what do we see under the microscope? Everything looks the same, no? So don't worry, है ना? As you look at the details, we learn. So this is all for visual impression. That's important. Visual impression is there. You will be able to understand it better. So now I'll put the doubts here. Okay, let me put the doubts here one by one. Let me put the doubts. So first question, everybody, I'm going to type it out only for you so we can not have any controversies here. Okay, so I'm going to type it out for you. What are the doubts? I'll type it out for you so it remains here. Okay, so what doubt number one is why ANA is having more than 98% sensitivity. Sensitivity means what? It is present. That means it is present in 98% of the cases. So sensitivity means it is present in 98% of the cases, and that is why it is done as the screening. Screening means to see whether the disease is present or not present. So everybody, many questions were there that whether sensitive means what? Common, not specific. It is common. So many autoimmune disease will have. Another question was there, which organ specific? Which organ specific have ANA? So answer, many are there. Okay, so your thyroiditis, example I am giving, thyroiditis can have ANA positive. Pernicious anemia can have ANA positive. Okay, so ANA positive is non-specific. It is non-specific. It has no important relevance here. So we will know here. Okay. So further question, what we have got. So you said yes. So ANA overlap syndrome, can ANA be positive? Yes, that we have said. So when do you call it overlap syndrome? Overlap syndrome is when both, when both ANA and RA factor are positive. So when do you call it? When both antibodies are positive, we are going to call this as overlap syndrome. Yes, we'll increase the size, so there is no problem. Right? Okay. So these are the common doubts that I was getting. So why in females? Anna, in females after pregnancy. So after pregnancy, because pregnancy, there is a fetus, that is a foreign body. Pregnancy does not occur in males. That's why it is more common in females. That's why I said, hence it is more common. Hence the autoimmunity is more common, I said. Autoimmunity is more common in the females. That's what we know. Okay, we cannot prevent progression. There is no need to prevent. So when do? We do RA factor and ANCA only if the relevant symptoms are present. Only if relevant symptoms are present, then only we will use them for screening. So when you don't have specific symptom, we don't do those tests. We do first ANA testing. First we do ANA testing. That's what we want to do this, right? So this is what we have got it here. So ANA, first we do ELISA. First we do ELISA. As I told you, because it is cheap. Because it is cheap, but it is not specific. Because it is cheap, but it is not specific. That's the problem. And then to confirm ANA positivity, it is not anything else. To confirm ANA positivity in significant titers, ANA positive in significant titers, you want to do the immunofluorescence method. So immunofluorescence is done. So it is not that immunofluorescence tells you exact disease. No, it is just to confirm whether it is significant titer. And only in significant titers, the pattern, immunofluorescence pattern is relevant. Otherwise, you will not give importance. Only in significant titers, you will say pattern is relevant. And last question, saying why not do specific antibody directly. Last question here, why not do specific antibody directly? Answer is very simple, because each costs 3,000 rupees. Each is costing 3,000 rupees. That's why we don't do it. Okay, so keep it simple. Anna, all these are clinical related questions that I want you to know. Right till here? So we will proceed further. So we'll proceed further from here. So what we have done till now? So what we have done? We have all become now, hopefully, a good MBBS in rheumatology. Please remember what MBBS doctor is supposed to do. What the MBBS doctor is supposed to do? MBBS doctor is supposed to know basics. That means normal immunity. Normal MBBS doctor must know what is autoimmune disease and what is the screening test. So as a family doctor, what are the 3 rules of family doctor? Listen everybody, 3 rules of family doctor. First is early suspicion. To suspect disease, I must know about disease. Number 2, early screening. So I must know ANA test. So as a MBBS, I must know common when to suspect. I must do what test to do. And third job is what? Early referral. Third job is early referral we have to do. So we have to refer the patient to rheumatologist, which you are all going to become now. So in the next week, over the next week, we are all going to become rheumatologists now. So rheumatology fellowship can begin now. All of you know physiology, first MBBS. You know pathology, second MBBS. You know ANA testing, that is also pathology, and you know classification, that is basic medicine. So you know basic MBBS. Now we want to know exact details of the disease and how to manage individual disorders, right? So let's go forward. So today we are going to focus on lupus disorder. So today's class we are going to focus on lupus disorders. Today we are going to focus on lupus disorder. Okay, that's what we want to look. So Priya Rai, the same question on a common pattern in SLE. Anna Sushmita Reddy has already replied correctly. It is different. Most common in SLE, homogeneous. Overall most common pattern in laboratory, that is speckled pattern, right? So let us move it forward. Chalo. Right, everybody? So far so good. Let's continue further. Let's come to the recall here. Classifications. Let's come here. Right. So what is this first point? Recall of the classification. Everybody now together. Okay. Now we are not MBBS anymore. Now we want to become a specialist. Little more interaction, little more seriousness. Let's go for this. So what is the first point? So lupus group of disease, ANA, positive, we are going to focus upon. So lupus group of disease, we are going to focus upon now. So if ANA is positive, lupus disease. Now further. Among this, what we want to know, as I told you, how do you classify lupus further? Please pay attention. You say the lupus further when there is a characteristic feature antibody present. Then you give the individual name, whether it is SLE, whether it is scleroderma, which is now called systemic sclerosis, or it is Sjogren's syndrome, now called Sicca syndrome. So what is the simple point? Come on, I want you to write. This is recall. Immunofluorescence pattern, quick recall of what you have written. Homogeneous means SLE. Centromere means limited systemic sclerosis. Nucleolar means diffuse systemic sclerosis. And speckled means probably Sicca syndrome. I am limiting our discussion to lupus group. The three lupus disorder I am focusing upon. Three lupus disorders I am focusing upon. Right? Chalo. So how do you classify lupus disorders? Write down, everybody. How do you classify lupus disorders? Let us try to write it. So based on what are the points? How do we classify? How do we classify? One, characteristic feature and the specific antibody. So 2 points we are going to take. So again, come to the point here. If the patient comes with suspected rheumatology disease, you do ANA test. ANA test has come positive in significant titer. You know this is lupus disease. Within the lupus disease, you want to make the final diagnosis, for which you need to focus on these two characters. One, whether the characteristic feature is there and whether the specific antibody is present. Only when both are present together can you confirm the disease. So feature of the disease with the relevant antibody together confirms the disease. Only feature can be symptom of any disease. Only antibody is only autoimmunity. So to confirm the disease, we need to have both. So first point, how do you know? When do you call lupus disease as SLE? Now what we have done, ANA positive means we have reached the group. We know it is lupus disease. But when do we say the lupus disease is SLE? Anna, as the name says, please focus. What is the name saying? Name is saying, so SLE, limited sclerosis, diffuse sclerosis, Sicca syndrome. I want you to write down, make this table and tell me the answers to the empty column. Come on. So make this table and we will write down the answers to this empty column. So in a lupus disease, how to make the diagnosis when it is SLE, when it is limited systemic sclerosis, when it is diffuse systemic sclerosis, when it is Sicca syndrome. How do we make? Start with number 1. Very good. SLE. Anna, write down the full name. Understand. What is the name? Systemic lupus erythematosus. Why the name was given? SLE name was given because of the characteristic blood red rash. So the name itself carries the answer. It is given the name because the characteristic feature is blood red rash. Don't talk malar rash, discoid rash. That's not important. Focus on the name. Erythematosus is important. And we just discussed immunofluorescence pattern. Compare the table. Which is the specific antibody? Anti-Smith, anti-dsDNA. Anti-Smith, anti-dsDNA. So along with rash, in a lupus group, patient has red rash and dsDNA. Then together we call that final diagnosis as SLE. That's the approach here. When to call limited systemic sclerosis? Yes, everybody, keeping up with the table, move forward. Come on. When do you call it limited systemic sclerosis? So systemic sclerosis are of two types. Systemic sclerosis are of two types. So limited systemic sclerosis, CREST syndrome. Another name for limited systemic sclerosis is CREST syndrome. We will read along with the disease. And the specific antibody we just saw, anti-centromere antibody. Specific antibody is anti-centromere antibody. So coming to number 2, limited systemic sclerosis you will diagnose when patient has features of CREST syndrome, anti-centromere antibody. To confirm, patient must have both, characteristic feature also and antibody also. Then only you can confirm the diagnosis. So diffuse systemic sclerosis, generalized skin involvement is there. So scleroderma, as the name says, areas of skin fibrosis. But here it is generalized, including the trunk also. Diffuse, the name is telling you, diffuse. It is having diffuse. And there is anti-SCL70 positive. So the specific antibody is the topoisomerase 1, commercially called SCL70. Anti-SM is anti-Smith. SM full form is Smith. Anti-Smith antibody we are going to have. Features of CREST syndrome we will discuss along with the disease. This is a summary. This is enumeration of the points here to make you understand approach. Sicca syndrome, as the name says. When do you say patient has Sicca syndrome? Sicca means dry. Sicca means dry. So there is a sicca, dryness of eyes and dryness of mouth is present. And if the patient is positive for anti-Ro, anti-La, which is now called as SSA, SSB, we can confirm it is Sicca syndrome. So understand, in rheumatology, approach is very, very simple. Approach is very, very simple. So again I'm telling, see, basics are important. That's why I'm emphasizing again and again. Because once you come to individual disorder, it is more theoretical discussion. What is important is to first grasp the clinical approach to understand the disease. SSA, full form I have told you, Sicca syndrome A, Sicca syndrome B. That is the new name of the antibody. Okay, SS, Sicca syndrome A, SSB, Sicca syndrome B. That is the full form that we have here. Right? So remember, okay, so doubts done. This is what we have got. So all our doubts we have solved till now. We have reached here. Okay, no, Smith is different, histone is different. We are going to come to that when we read SLE. So far so good. Today we are going to discuss in detail lupus disorder. So today's class we are going to discuss lupus disorders. Okay, Ro and La are old names of the same antibody. This is what we are going to discuss here. Chalo. So recall what we want to do about every individual disease. Please remember, about every individual disease, what we want to know? We want to know definition, epidemiology, etiopathogenesis, clinical feature, diagnosis, treatment and prognosis. From now, the class will be fast because you know what to expect. Okay, I hope you are all in synchrony with me now. We know how to suspect, how to approach, and about each disease, I want you to make in mind, these are the points you have to write. about every single disease anywhere in medicine, surgery, OBGY, wherever you study disease to solve any MCQ. These are the top points that you want to know about the individual disease, right? So let us go forward. So let us start with the first disease. Yes? Okay, chalo. Right. So let us start with the first disease, that is SLE. First disease, that is SLE. Okay. Most common lupus disorder. As I told you yesterday, about every disease, we must know what is important about the disease and why we must read that disease. We must know. So SLE is obviously important. It is the most famous rheumatology disease that we know, and it is because it is the most common lupus disorder. Most common lupus disorder, right? So what is the epidemiology? When to expect SLE? So you will suspect SLE epidemiology in a young female, 20 to 30 years. In a young female, this age group, this is called childbearing age group. This is called childbearing age group. We want to write. We will expect SLE. In this age group, we will expect SLE to occur. What comes? Definition, epidemiology, etiopathogenesis. So we must know what is the cause of SLE. Write down everybody. What is the cause, etiology of SLE? What is the etiology of SLE? Most cases are idiopathic. Most cases of SLE are idiopathic. Okay. And 1 to 5% is drug induced. So what is that? You will write down the short form. Drug induced lupus. Ana thoda dil. We will put dil here. So that will be our concluding topic for tonight. So today we are going to discuss SLE in detail. That's what is our target for today's class. So again I'm telling you, most common cause of SLE is idiopathic. That means we don't know the cause. 1 to 5% may be drug induced lupus. So in the idiopathic disease, even though we don't know the cause, what do we know? We know risk factors. Write down. Even though we don't know the cause, we know risk factors. So we'll make a small table for risk factors. We can say risk factors. Right? So risk factors are those which are associated with increased risk of developing SLE. So compared to a normal population, these people are at a risk of developing SLE more. So they are not exactly cause, but they are basically going to have what? The risk of developing SLE. We want to know, right? So continue further here. Write down risk factors, classify according to the group, make a table. Classify according to the group. MCQ also. MCQ is going to ask you most common genetic risk factor, most common chromosomal risk factor, most common infection and toxin exposure. So make it a MCQ friendly table. MCQ friendly table. That's the name. We must say MCQ friendly. Our notes have to be. Whatever can be asked, we have already written down. Learn to apply that in the question which is asked. Come on. So what we have got? In the genetic risk factor. Everybody with me? Writing with me? Yes. So what we have got here? TREX1 gene defect. Most common genetic risk factor. Most common, the genetic risk factor is the TREX1 gene defect. Most common genetic risk factor is the TREX1 gene defect. Next point, chromosomal. Which chromosomal defect? Most common is Klinefelter syndrome. Most common is Klinefelter syndrome. When you talk of chromosomal defect, most common is Klinefelter syndrome. Okay, Klinefelter syndrome. Infection. Most common infection. associated is chronic Epstein-Barr virus infection. Chronic Epstein-Barr virus infection. So most common infection. Many people believe, many studies feel that actually SLE is a chronic infective stage of Epstein-Barr virus. Okay, so it is an important risk factor for development of the SLE. Toxin exposure. Which toxin is responsible? Ultraviolet rays and silicosis. Please remember, ultraviolet ray and silicosis are responsible for the disease. Ultraviolet rays and silicosis are risk factors for development of SLE that we want to know. So these are general risk factors that we know, even though we don't know any specific cause except when it is drug induced. Okay. So again, what we know: definition, epidemiology, etiopathogenesis. We know pathology, all autoimmune disease. So come to clinical feature. Come to clinical features. Right. So clinical features. Write down clinical features one by one. Clinical features: cutaneous disease. Cutaneous disease, specific but 30 to 50% only. There is always a dictum. We say that the most common department diagnosing SLE is the dermatology department. Most common department diagnosing SLE is dermatology department. Why? Because they have the privilege of seeing the most specific manifestation. Please remember, specific does not mean most common. Specific does not mean most common. Specific, if the cutaneous rash is there, it is very likely that it is SLE, but it is seen only in 30 to 50% only. It is seen only in 30 to 50% only. Let us see this one point here, only 30 to 50%. So cutaneous manifestation are subdivided into two. Cutaneous manifestations are subdivided into two. One is the acute cutaneous. Acute cutaneous is called malar rash. Acute cutaneous is called malar rash. Chronic cutaneous is called discoid rash. Chronic is called discoid rash. So let us look at the picture and you can write the description. I will show the picture, you can write the description. So what we have got here, in acute malar rash, acute malar rash, acute cutaneous, almost the hallmark of SLE. In a young female, you see blood red rash in the malar, maxillary area. How do you describe? Write it down for me. I have written the description for you. Take it down. It is a erythematous. Each word is important. It is erythematous. That is why the name SLE. Erythematous. I am writing it for you. Erythematous macular rash. What do you mean by macule? Macule means flat, not elevated from the skin surface. Macule means flat, not elevated from the skin surface. So there is a blood red rash present. Where it is there? Over the maxillary area, and typically sparing nasolabial fold. Typically sparing nasolabial fold is the most characteristic of SLE. So if a young female comes with acute malar rash, it is not most common, but when it is present, you are almost certain that she is a case of SLE. You are almost certain that she is a case of SLE. Okay, that is the meaning of specific. Compare it to discoid rash. Let's compare it. Compare it to discoid rash. What is comparison? It is a chronic. When a disease becomes chronic, what will be there? Fibrosis. In chronic, there is fibrosis. So how do you describe? It is a fibrotic. So the description will be fibrotic, painless, papillonodular. Papillonodular means elevated, elevated from the skin surface. it is fibrotic, it is painless, it is papulonodular, that means raised. Okay, macular means flat, papulonodular means elevated rash seen over the scalp, face and the neck area. Seen over the scalp, face and the neck area. So cutaneous manifestation, write it as 1 and 2. Acute is malar rash 1 and 2 is the chronic discoid rash. So what are we going to do? Make in a chart format. Clinical features of SLE. Write 1, 2, 3, 4. Clinical features of SLE. Feature number A, cutaneous involvement. Cutaneous is specific but not common. Among the cutaneous, there are two, acute malar rash and the chronic discoid rash. Correct? So we have got two, 1 and 2, acute and chronic cutaneous manifestation. Number 3, write down. Number 3, rash is not painful. Rash is not painful. Why it occurs in that part is not known. Okay. So coming back to third point. What is that? Synovitis. Very, very important. Number 3, synovitis is there, which is most common but non-specific. Synovitis means there is joint pain and swelling. Joint involvement is there. So if somebody asks you what is most common organ affected in SLE, answer will be joint, musculoskeletal system. Note it please. Most common system involved will be joint, musculoskeletal system. But we all know that joint involvement can be feature of RA also, can be a feature of arthritis also. So we cannot say it is specific. Joint involvement can occur in SLE also in the form of synovitis. Let us write down further. What about synovitis? So important point to differentiate from RA. Write it down please. How to differentiate from RA? One clue. SLE affects the small joints. SLE also affects the small joints like RA. SLE also affects the small joint. But what is it? More commonly asymmetrical pattern. One important point. In RA is typically symmetrical arthritis. RA is a symmetrical arthritis. While SLE, even though joint is same, but the usual involvement is asymmetrical. That is a clue. Asymmetrical is a clue. Okay. So don't worry. First two clinical features are only done. For those who have missed, I will show you in the end just that cutaneous feature. Okay. Please continue. Just you have to write in your notes clinical features of SLE. Start number 1, acute malar rash. Number 2, chronic discoid rash, and continue with this page. Okay. That manifestation I will show you in the end. Continue from here please. Okay. 1 and 2. Just you have to enumerate. That's all. Description, it is just for your understanding. So synovitis is most common. It can look like RA, but one of the clue is asymmetrical pattern. But also what it can cause. So there was a question, can SLE joint involvement cause deformity? So answer, yes, it can cause deformity. What is the deformity called? Jacob's arthropathy. The deformity is called Jacob's arthropathy. It is called as Jacob's arthropathy. Okay. What is written before asymmetrical pattern? It is asymmetrical pattern. After Avni Kotari, after that we have written asymmetrical pattern. Yes, okay. So it can cause what is called as Jacob's arthropathy. It is called as Jacob's arthropathy. So Jacob's arthropathy, look at the picture with me. Jacob's arthropathy, when you look from outside, when you examine the patient, there is joint pain, there is swelling. So what it can do? It can look like RA. So when you look from outside, the joint involvement clinically can look like RA. Joint involvement can look like RA. But what is different when you do the X-ray? So from outside, joint involvement may look like RA, but when you do the X-ray, what do you see? There are no erosions. When you do the X-ray, what do you see? There are no erosions. Very good. No, Aisha Samin, correct answer. There is no residual deformity. Very good. So what is important? It is usually asymmetrical and X-ray shows no bone erosion. I have written it in blue because this is the difference from RA. This is the clue to differentiate from RA. Yes, swan neck and all is just a name of deformity, shape of the deformity. But this presentation is typically called Jacquard's arthropathy in SLE because X-ray shows no bone erosion. There is no bone erosion. So what is it? Because their bone is not involved, it is soft tissue. So the deformity is reversible. Because there is no bone involvement, the deformity is reversible, and hence the presentation is called non-erosive arthritis. Very good. Presentation is called non-erosive arthritis. The presentation is called non-erosive arthritis. We are going to call. Okay. So after the risk factors, again few people app is crashed. Please don't worry. Just restart. I'm going at very comfortable pace. We have started enumerating clinical features of SLE. That's all. And we are at number 3. You can take a snapshot and move on maybe. Just we are at number 3. First we have discussed cutaneous manifestation, which I am going to again repeat in the end for you. One slide cutaneous I will show you in the end. So again I am telling you, swan neck deformity is just a name. Whether it is RA or SLE, you will know only when you do X-ray. You can identify only when you do X-ray. Okay, this is non-erosive arthritis. Continue further. So we have written 3 clinical features. We have written 3 clinical features. 1. Acute malar rash. 2. Chronic discoid rash. 3. Synovitis, also called non-erosive arthritis. We have written 3 clinical features. Coming forward, change color. So we are going to enlist further. We are going to write further features. But what important? I have put an asterisk here. Whatever are life-threatening. Because till now what did we study? Skin and joint. Skin and joint involvement cannot cause death of the patient. They are not life-threatening. But whatever we are going to write in red are going to be life-threatening. So among the various clinical features, we are going to write life-threatening features in red. Life-threatening features in red. Right. So what we are going to do? Right. So number 4, there is the non-scarring alopecia. Number 4 feature, non-scarring alopecia. The deformity is reversible because it is only soft tissue. You can stretch the finger and put a splint. Bone is not involved. That's why it is called reversible. You can make it straight with force and put a splint. In bony deformity, in RA you cannot bend it. It is bone is gone. So that is why SLE it is called reversible. Number 4, non-scarring alopecia. Non-scarring alopecia is there. Right? Next one is serositis. Next manifestation can be serositis. Serositis we saw with FMF yesterday. Pleural cavity, pericarditis can be life-threatening. That's why red color. Pericarditis can be red color. Pericarditis can be red color. Okay, because life-threatening manifestation. Number 6, patient can also come with oral or nasal ulcer. Patient can come with oral or nasal ulcer. oral or nasal ulcer. Number 7, patient can have renal involvement. Renal involvement is most common cause of death in acute SLE. That is why in red, renal involvement occurs in the form of glomerulonephritis. Renal involvement occurs in the form of glomerulonephritis. Glomerulonephritis, renal involvement can occur. Number 8, CNS involvement. Number 8, CNS involvement. Anna, Prachi Yadav, you are asking how alopecia is life-threatening. I said life-threatening, we are writing it in red. This is not red color, this is black color only. Only the life-threatening we are writing in red color. Okay, right. So CNS manifestations, neurological system can be affected in the form of convulsion, psychosis. Convulsion, psychosis. That's why it is also called neuropsychiatric manifestation of SLE. That's why it is called neuropsychiatric manifestation of SLE. Okay, neuropsychiatric manifestation. Further, it can be hemolytic, hematological involvement. Hematological involvement. There can be hemolytic anemia. Hemolytic anemia can be there. Thrombocytopenia can be there. Thrombocytopenia can cause bleeding, that is coagulopathy. Thrombocytopenia can cause bleeding, that is coagulopathy. Okay, and number 11, patient can come with leukopenia. Patient can develop leukopenia, that is defined as WBC less than 4,000 or lymphocyte count less than 1,000. Lymphocyte count less than 1,000. Okay, so again, what are the features? 11 clinical features of SLE. Everybody pay attention. There are 11 clinical features when you must suspect SLE. I have told you na, what is approach? Clinical suspicion. When a young girl comes to your clinic with any of the 11 clinical feature, one of your differential diagnosis must be SLE. What is number 1? Acute malar rash. Repeat with me everybody. Acute malar rash. Number 2, chronic discoid rash. Number 3, synovitis, non-erosive arthritis. Number 3, synovitis. From here onwards, number 4, non-scarring alopecia. Number 5, serositis. Number 6, oral nasal ulcers. Number 7, glomerulonephritis. Number 8, neuropsychiatric manifestation. Number 9, there can be the hemolytic anemia. There can be number 10, coagulopathy. Number 11, leukopenia. Out of this, you can clearly see there are only four life-threatening features. For MCQ, there are only 4 life-threatening features. Okay, so Hemant Panchal has a good question. Why leukopenia is not life-threatening? That's an interesting question. Why leukopenia is not life-threatening? Because they say in SLE, the WBC function is not affected. The number of WBC has become low, but the function of the WBC is preserved, and that is why usually life-threatening infections don't occur. That's why we don't include it under life-threatening manifestation. Okay, that's a good question. That's a good question. So we have enumerated. So when patient has one or more of these clinical feature, what you will do? Suspect the diagnosis. What you will do? Suspect SLE. We have to suspect. Next. Once you suspect the SLE, what we have to do? Follow the SLIC criteria. Please write down. We have to follow SLIC criteria. we have to follow SLIC criteria for the diagnosis. After you suspect, we follow SLIC criteria for the diagnosis. Now, before you say what is SLIC criteria, answer is in front of you. So it is Systemic Lupus International. We are on this line. I'll keep the pointer on that line. So Systemic Lupus International Collaborative Clinics Criteria. Okay. Systemic Lupus International Collaborative Clinics Criteria. So for the diagnosis of SLE, if you have got the feature, you want to use SLIC criteria to confirm the diagnosis. What does it involve? What does it include? So write down. The SLIC criteria includes number 2 line, 11 clinical criteria that we just studied. We just studied 11 clinical criteria, right? All the clinical manifestations are our clinical criteria. So we studied the 11 clinical manifestation. They translate into the 11 clinical criteria and 6 immunological criteria. That is 6 serological tests that can be used for diagnosis of SLE. So you can understand. So suppose patient comes to my clinic, I suspect SLE, I see because there are 2 or more clinical criteria. One is also enough, but at least one should be there. And if more than 4 are positive, more than 4 criteria are positive, then it is confirmatory of the disease. 4 or more criteria, but what is the point here? At least one of each criteria. All 4 cannot be clinical. I told you, only clinical feature can have other causes. Only antibody can be physiological. So when patient has clinical feature plus corresponding antibody, then what do? You confirm SLE. You confirm diagnosis. So according to this criteria, you need total of 4, but at least one clinical, at least one immunological to confirm the diagnosis. 11 clinical criteria already done. What about immunological criteria? Write down with me. Number 1, what will you do? First, screening. Immediately for screening, what I can do? ANA. Already we have discussed in detail. For screening, we will immediately do ANA, available for screening. Also, what is specific? Next to, please write down anti-Smith, and anti-dsDNA. Anti-Smith and anti-dsDNA because they are specific. Because they are specific. We can also do APLA. We can also check for APLA, anti-phospholipid antibody, because they are sensitive. APLA, anti-phospholipid antibody, also you can check. Next one, anti-erythrocyte antibody. You can check for anti-erythrocyte antibody. Again, I am telling you, in your clinical practice, you will never see anti-erythrocyte report because the commercial name is DCT. Remember, DCT, direct Coombs test, is the laboratory name for anti-erythrocyte antibody. So DCT is same as anti-erythrocyte antibody, direct Coombs test, direct Coombs test. Okay. So we want to see. Okay, I'm noting down your doubts. We will not diverge from the topic. I'll note down your doubts. Okay, and then discuss in the end. We'll note down the doubts. So we can do DCT and we can also check for serum complement levels. So number 6. So 6 immunological criteria. We can check for complement level. And in SLE, they are persistently low. Please highlight that. They are persistently low, favors the diagnosis of SLE. Other antibodies should be present. all these tests are approved. We don't have to do all criteria. All these 6 immunological tests are approved for the diagnosis. Total we want only 4. So we will do first ANA, we will do anti-dsDNA. If it is positive, end of the story. Total 4 criteria ho gaya. Then you don't have to do further testing. But we want to know criteria कि कौन से टेस्ट कर सकते, which test can be done, all 6 of them can be done. So right, we have got clear 11 clinical criteria are there, 6 immunological criteria are there, and we can test for them. So total, if there are more than 4 criteria positive, at least one of each, then it is confirmatory of the diagnosis. So this criteria looks very user friendly. Please remember, this is very user friendly. User friendly means what? It is easy to remember. You just have to count. Rash is present 1 point, synovitis is present 1 more point, like that. But what is the fallacy? The fallacy is there, no? Fallacy of the criteria is each parameter is given the same weightage. Are you understanding? Each parameter is given same weightage. Now malar rash is specific for SLE. How it can get same weightage as synovitis, which is non-specific? So it is a fallacy. This criteria has got a problem that it is giving equal weightage to all the manifestation. It is giving equal weightage to all serological tests, though each manifestation has different specificity. Each test has different specificity. That is why we have to know the update. We have to know the update, right? So we have to know update of SLE diagnostic criteria. We have to know the update. So we will know the update. What is the change that has occurred in this criteria? What is it? Then we have got the SLE diagnostic criteria we want to know. Okay. So 4 criteria we want to know. Anna, Aditi is asking still 4 criteria. Are 4 out of so many, no? 11 plus 6, 17 में से 4. Out of 11 clinical plus 6 immunological, you need total 4. That's all for diagnosis of the disease we want to know, right? So what is the update? Update number 1, they have included a word entry criteria. No, you don't have to write this. You can just understand. Don't have to write this. Just watch this. I have put it in the images, class images. It is available. Just focus on what is update. So what they have done, new update is ANA has to be positive. But they have given less titer. At least more than 1:80 titer is there. That is enough to classify, consider ANA. So what it becomes? If absent, then it is not SLE. So 20th edition Harrison still says, please focus, that the 20th edition Harrison says that rarely SLE can be ANA negative. That line is no longer correct. According to the update, SLE can never be ANA negative. Minimum titer 1:80 has to be there. Minimum 1:80 has to be there. So what is the first change? Entry criteria. First change, entry criteria has come. ANA has become compulsory. ANA has become compulsory for diagnosis. Next one, clinical criteria. What is the update? Let us see. Come on, review with me. What are the clinical criteria we have written? We have written acute malar rash. We have written chronic malar rash. 1 and 2. Follow the laser. Follow the pointer. We have written acute cutaneous, chronic cutaneous. We have written synovitis. We have written synovitis. We have written non-scarring alopecia, serositis. We have written oral ulcer. We have written neuropsychiatric. We have written renal. We have written hematologic manifestation. So what is there? We have got one extra point. So according to the update, now fever is also included. Fever is also included for diagnosis of the disease. So focus on what is different. Don't write the criteria. Focus on what is different. So ANA is now compulsory. Number 2 change, fever is included as a clinical criteria. Fever is included as a clinical criteria. Next one, immunological domain. What we have written, ANA has now become compulsory. So anti-Smith, anti-dsDNA, that is there in SLIC also. Low complement, there in SLIC also. Anti-phospholipid, there in SLIC also. So what is there in SLIC but no longer recommended is DCT. Direct Coombs test is no longer part of the diagnostic criteria. So direct Coombs test is no longer part of the diagnostic criteria. So three important changes I want you to note. Just write what are the changes you write. Don't write the whole thing. Write what are the changes. Change number 1, ANA is now compulsory. Fever is now clinical criteria. And DCT is no longer immunological criteria. DCT no longer immunological criteria. That's what we want to know. So we must understand why this change. Why this change was there. So old criteria was the ACR criteria. American College of Rheumatology. Don't have to write. This is just for your information. Don't have to write. Only for information. ACR, American College of Rheumatology, old criteria was very, very specific but not sensitive. It was very specific but not sensitive. So what happened? We got SLIC criteria. SLIC criteria came in 2012. SLIC criteria is very, very sensitive. But because it gives weightage, equal weightage to all, it loses specificity. It is sensitive. It will not miss the diagnosis. But because it gives equal weightage to all the manifestation, it loses the specificity. And that is why by the new update, what we have done now, made the criteria both sensitive and specific. New criteria. Yes, we have to learn the new update. Of course, you have to learn the new update. But as I am telling you, I am making it easy for you. It is same as SLIC criteria. Just to highlight the change and you have learned the new criteria. That's all. So it is a very simple method. What is relevant? Again, MCQ friendly rakho bhai. Focus on what can come. Focus on what can come. We want to know. Right? That's what is the point here. So come to the management. So what we have done, we know the definition, epidemiology, etiology and clinical features of SLE. We also know how to diagnose SLE using SLIC criteria or the update criteria. Now we know how to confirm the criteria, diagnosis of SLE. Okay, again Priya is asking what is DCT? DCT, direct Coombs test. We have written no just now, direct Coombs test. So coming to management. So once we have got this, we have come to the management. Management of the disease. Management of the disease we want to write. So management of the disease. What is important? Learn this dictum. In medicine, it is important to know the presentation. Is it serious or is it comfortable? It is non-life threatening. So it depends upon the presence of life-threatening manifestation. Note that point. It needs the presentation, life-threatening manifestations. We need to know. Life-threatening manifestations. We have already written it. Which are they? I am just enumerating. Don't have to write again. What can be life-threatening? Pericarditis, renal failure, neuropsychiatric manifestation and coagulopathy. Pericarditis, there can be the renal involvement, there can be neuropsychiatric and there can be the coagulopathy, can be life-threatening. If any one feature is present, we are going to call this as autoimmune crisis. So any one feature is present, we are going to call it as autoimmune crisis, right? We are going to call it as autoimmune crisis. So if the patient has come with an autoimmune crisis, the drug of choice is methylprednisolone, IV methylprednisolone. If the patient comes in autoimmune crisis, the drug of choice is IV methylprednisolone at the dose of 1 gram per day for 3 to 5 days. That is why we call it famously as pulse therapy. How do we give prednisolone? 1 gram every day for 3 to 5 days. That's why it is called as pulse therapy. That's why pulse therapy we want to know. So autoimmune crisis, IV methylprednisolone is the drug of choice. Is the drug of choice, right? So this is followed after giving 3 to 5 days of IV methylprednisolone. It is followed by oral prednisolone. After first giving IV prednisolone, it is followed by oral prednisolone at the dose of 1 to 2 milligram per kg per day. So after giving you are going IV, you are going to continue with oral prednisolone. But if the patient does not have life-threatening feature, if the patient does not have life-threatening feature, if the patient does not have life-threatening feature, you call it as mild SLE flare. You call it as mild SLE flare. And then you can directly start with oral prednisolone. You can directly start with oral prednisolone. You can start with oral prednisolone. Okay? Oral prednisolone is given for 6 to 8 weeks. Listen and write carefully. 6 to 8 weeks. But followed by tapering of steroid. Because we all know that steroids have their own set of side effects. So you want to taper the steroid. But as we discussed yesterday, immunosuppression has to continue. So pharmacology teaches us you have to start on steroid sparing agent from day one. So whenever you give oral prednisolone, you have to also start the patient on steroid sparing action. Please note pharmacology. Minimum time for onset of action is 6 weeks. So it takes minimum 6 weeks for the steroid sparing agent to work. That is why till that time you cover the patient with steroid. After the steroid sparing agent has taken over, you can taper the steroid. After the steroid sparing agent action has started, you can taper the steroids. And that is the meaning why you are writing it as the steroid sparing agent started from day one. Yes, immunosuppression is considered lifelong. Immunosuppression is considered lifelong. That's because there is no cure to the disease. There is no cure to the disease. Yesterday I told you, idiopathic disease. That is why no cure to the disease. We have to continue. So next question, which are the steroid sparing agent? Next question, which are the steroid sparing agent? Come on. So what is the choice? Let us write. What is the choice of steroid sparing agent for long-term immunosuppression? So what are the steroid sparing agent for long-term immunosuppression? Let us write down in the order of convenience. Which one we have to choose? Write it down with me. Okay? Dose of steroid has to be remembered. Okay? Other drugs you don't have to remember the dose. Yes, very much correct. Anna? Trump's favorite drug is number 1 now. So first the choice is hydroxychloroquine. So along with the steroid, you are going to start the patient on hydroxychloroquine. Anna, for those students who are finding difficult what is steroid sparing, please read pharmacology. Okay, so you'll be able to make the connection. Hydroxychloroquine, because of the safety, has now become number 1 choice. Followed by mycophenolate mofetil. followed by mycophenolate mofetil. Then you can choose azathioprine. You can give azathioprine. You can give cyclosporine. Azathioprine, cyclosporine can be given. And last choice is usually methotrexate because it has its own set of toxicity. It has its own set of toxicity. So methotrexate comes in the end. So along with steroid, you are going to start the patient on steroid sparing agent for long-term immunosuppression. But all these agents take minimum 6 weeks for onset of action. Note it. They take minimum 6 weeks for onset of action. And that is why you will start tapering steroid only after 6 weeks. You will start tapering the steroid only after 6 weeks. Yes, it is going to be there that you have to continue steroid sparing irrespective of the severity of the SLE. Right? Next one. For refractory case. For the refractory case. So if the patient does not respond to steroid, if the patient does not respond to steroid, we also have anti-B cell therapy is approved. For patients who do not respond, we have got the anti-B cell therapy is approved. Anti-B cell therapy is approved. Yes, steroid sparing continue करने का. Steroid के साथ along with steroid you have to give. So which are these two? Which are these two you want to know? So yesterday in physiology we studied what is B cell. B cell expresses CD20. We studied that B cell express CD20. So one drug we can give monoclonal antibody. Monoclonal antibody against CD20. Monoclonal antibody against CD20 is one of the choice. What is it? IV rituximab. Monoclonal antibody. MAB is monoclonal antibody. Rituximab. What does it do? Eradicates the B cell. What does it do? Eradicates the B cell from circulation. So one way anti-B cell action, you can remove the B cell. Or what can you do? You can give monoclonal antibody against BAF. You can give monoclonal antibody against BAF. That is B cell activation factor. The drug is IV belimumab. The drug is IV belimumab. What does it do? Prevents activation. What does it do is it prevents activation. That's how we can control the SLE. So please remember here, okay, how to manage SLE is a process. After the diagnosis of the patient is done, steroids are drug of choice for acute presentation. So either you give IV followed by oral if the patient was in a crisis. That means life-threatening situation. Otherwise, you start directly with oral steroid along with steroid sparing agent. After 6 to 8 weeks, you will taper and stop the steroid. You will continue only steroid sparing agent. After some time, majority of them will get new symptom. New symptom should be counted as new attack. And that time, again you will give steroid for some time. Then either you will add another steroid sparing agent or change the steroid sparing agent to continue immunosuppression. That is how you have to manage the immunosuppression protocol in SLE. In SLE. So in HCQ, very correct, everybody's answer, pregnancy. Pregnancy usually we say is a immunosuppressive state in itself, no? So SLE flares are not common in pregnancy. But HCQ, hydroxychloroquine is safe in pregnancy. Hydroxychloroquine is safe in pregnancy. You can continue. Steroid remains drug of choice. Even in pregnancy, if patient has got acute flare, you will give steroid. And you can also give hydroxychloroquine. That's what we want to know. That is our management. But before we close, we must know prognostic antibodies, right? So what we want to know, after the diagnosis, you started the treatment, but patient wants to know that what are the risks and how to know what is the risk of the disease. So please write it down. We have got the 4 groups of prognostic antibody. Let us write down the 4 groups of prognostic antibody. Make a table, and here we will write the significance. We will write clinical significance here. Here we will write the clinical significance. Okay, clinical significance. Please don't keep typing your doubts. I have noted it and I will come back to it. Okay, so please be patient. It's not funny, no, to keep writing same doubt. I got it. We'll come to that, right? So what are the prognostic antibody? Start with number 1. Start with number 1. Okay, anti-dsDNA, double-stranded DNA. Let's write it down. So we have anti-dsDNA. First one correlates with the disease severity. So along with being specific for SLE, it also correlates with disease severity. So suppose the dsDNA titers are high, then we say disease is high activity or disease is severe. That's one. It also predicts the risk of renal and CNS involvement. So dsDNA also predicts the risk of renal and CNS involvement. Okay, they are going to predict risk of renal and CNS involvement. That is the importance of prognostic value of anti-dsDNA. That is the prognostic value. Anti-Rho, anti-La, please remember that is specific for Sika. But in SLE, what are they doing? What are they doing in SLE? SLE because it predicts the risk of congenital lupus. Please remember, anti-Rho antibody can cross the placenta and affect the fetus in a SLE positive mother. So when the mother is having SLE, anti-Rho antibody can cross the placenta, affect the fetus and can cause congenital lupus. It can cause congenital lupus. So Rho and La, Rho and La. I will come to antibody names in the doubt section. I will come to that. Everybody is curious. Okay. So predicts the risk of congenital lupus. Next set, anti-neuronal and anti-ribosomal P. Anti-neuronal and anti-ribosomal P. Anti-rheuma predicts risk means if the patient of SLE has got this antibody positive, then the risk of developing the complication is more. That is what predicts the risk of complication. So these are life-threatening, no? CNS involvement. If neuronal antibody is there, ribosomal P is there, then we know that patient is at a risk of developing neuropsychiatric problems. Neuropsychiatric problem. Antiplatelet antibody. Antiplatelet antibody increased risk of coagulopathy. I think that is the straightforward. Platelet can destroy. The platelets can be destroyed, leading to coagulopathy. Platelet can be destroyed, leading to coagulopathy. That's how we can see. That's how we can get. So antiplatelet antibody is associated with increased risk of coagulopathy. Okay, so SLE is a autoimmune disease. Arpit M, all antibodies can be there. Anti-Rho can also be there in some patients. It has no diagnostic value. Okay, again you are confusing. It is not a one-line answer. The clinical feature, antibodies can be there in multiple diseases. That's why we have to clinically correlate the laboratory test. Okay, so continue further. So we in Asta Kanodia is asking which one should we do? Both are done always together. Anti-Rho and anti-La testing are done together. It is a pack. Okay, it is an associated antibody. It is done together. when actually it is the anti-row, which is going to be crossing the placenta. So after we confirm, so they predict means they cause, they don't cause. It is just prediction. That's all. They are exact pathology of each manifestation is not understood. It is just that you have to look at if it is present, then you have to tell the patient that there is a more risk of you getting the complication. That's all, right? That's how we want to look at this answer. So finally, to complete our SLE, come to prognosis. So finally, completing prognosis. We want to complete prognosis. So prognosis, write down points here to complete here. First one, most common cause of acute mortality is renal failure. Okay, if the patient is having SLE diagnosed case, most common cause of acute mortality is renal failure. Number 1 point. Number 2, most common long-term complication. Most common long-term mortality. Most common long-term mortality is thromboembolic event leading to heart failure. Most common cause of mortality is thromboembolic event leading to heart failure. Can occur here, right? So these are for MCQs. But please remember, our country unique problem. Opportunistic infections in immunocompromised patient. When patient is on immunosuppression, they are prone to opportunistic infection, also contributes significantly to mortality in our country. So it is going to give us problems more. So SLE prognosis doesn't look good. So what are the points? Write one by one. Number 1, unpredictable course of the disease. The patient might have visited your clinic in the morning, she was fine. In the evening, you might get a call that she has got a convulsion. Evening, you might get a call that she has become breathless, right? So unpredictable course of the disease is there. Number 1, ADR, adverse drug reaction is there of long-term immunosuppression. Adverse drug reaction is there of long-term immunosuppression. So problems with SLE we are writing. Unpredictable course is there. The treatment also has adverse drug reaction. Along with that, high cost of therapy is there. High mortality is there. Makes the prognosis poor. Makes the prognosis poor. So how it is? It's a sequence from definition to prognosis. Each disease we want to follow same proforma. We want to follow same proforma. We want to know what is the definition, epidemiology, etiology. Then enumerate clinical feature by which you will suspect disease. Then you must know what are the diagnostic test, diagnostic criteria. You will start the treatment, look for prognostic antibody, and then finally we come to the prognosis of the disease. Prognosis of the disease we want to see, right? So we have written here already most common cause. Answer is different. Most common acute cause is renal failure. Most common long-term cause is heart failure. So MCQ, there are 2 different MCQ that you have to read and mark the correct answer. Right? So let's come to the doubt section here. Let me solve them for you. Okay. So few doubts I have noted. So let me just go through them. So one simple doubt, what is EULAR? Okay, we will come to that, but just for information, it is the European League against rheumatism. It is the European League against rheumatism. Okay, let me come to the doubt section here. One question solved. Other people wanted what is thrombocytopenia? Thrombocytopenia is platelet count less than 1 lakh. Cutoff is less than 1 lakh. Next question, thrombocytopenia. Next question, what is better, anti-Smith or anti-dsDNA? Anti-Smith is most specific. Anti-Smith is most specific, but found in only 10%. Found in only 10% cases, and that is why not preferred in practice. So clinically, if I ask you whether anti-Smith is better or anti-dsDNA is better, I will say anti-dsDNA is better, because anti-dsDNA is sensitive, it is specific, and it is also prognostic. That is why obviously it is better than anti-Smith. We can say that. What is autoimmune crisis? Crisis means presence of life-threatening complication. Crisis means presence of life-threatening manifestations. That is the meaning of autoimmune crisis that we can say. HLA correlation repeatedly, HLA, DR3, DR4 can be associated, but it is non-specific. Okay, so that is HLA correlation, both anti-Rho, anti-La. So this is what we are looking at. Okay, so thromboembolic, please remember, inflammatory conditions are pro-coagulable, are hypercoagulable states. Leading to thromboembolism, leading to thromboembolic episodes. So only in the thrombocytopenia, only in low platelet, that time bleeding can occur. Okay, so both complications can occur. Okay, so we have got this here. So we got this clearly. So these are the doubts we have done till now about SLE. So, right, let's recall here. So what is the recall here? That we have completed till SLE. Please look at this carefully. So we have last 10 minutes to go, please. Last 10 minutes we want to know. Okay. Asif Ali, please don't ask irrelevant question now. Anna, focus on what is there. If I have not written, it is not there important for us at all, because we are not going to give it now. Okay. So what about this? So please focus on this. Last 10 minutes, everybody, don't ask questions till I finish. That is not fair. Okay. Without me finishing the topic, you will not ask random questions. That is not fair. So as I told you, one cause idiopathic. That's what is correct. One cause is idiopathic, but what is remaining is dil. Okay, so dil ke saath jayenge. Today we are going to close our class with drug-induced lupus. Let's read that together. Come on. So suspect. When to suspect drug-induced lupus? Come on with me, everybody. When to suspect drug-induced lupus? So right, last topic for today. Drug-induced lupus. Last topic. Okay, Ramya is still asking how long to give. Same treatment. In crisis also, steroid is given for 3 to 5 days IV. If patient is okay, convert to oral steroid. If patient is not improving, you have to change to refractory treatment. Anti-B cell therapy can be given. Protocol is the same, whether it is crisis or flare. Difference is whether to give IV steroid or start directly with oral steroid. That's all. Okay, hope that is clear. So coming to this, drug-induced lupus. What are the drugs? Let's enumerate. You will suspect only when patient is receiving offending drug for more than 2 months. Offending drugs more than 2 months. Most common offending drug are the cardiovascular drug. Let's write system wise. Make a table system wise table, right? Most common culprit is cardiovascular drug. Most common offending drugs are cardiovascular drugs. So ACE inhibitors, beta blockers, statins, alpha methyl dopa. These are much more commonly used, no, compared to hydralazine, procainamide. Second column, antibiotic, okay, isoniazid. No, discoid lupus is different, Baba. Discoid lupus is a rash. Discoid lupus is a rash. Only skin involvement, that is dermatology condition. Part of lupus, that is not separate type. This is drug-induced lupus based on etiology, right? Yes. So antibiotic, isoniazid, dapsone, sulfonamides. CNS drugs, neurology drugs, phenytoin and carbamazepine. Neurology drug, phenytoin and carbamazepine. Phenytoin and carbamazepine is there. Gastrointestinal, please remember, our medical students' favorite proton pump inhibitor can potentially cause lupus. Proton pump inhibitor can cause lupus. So proton pump inhibitor, sulfasalazine. Proton pump inhibitor, sulfasalazine. Endocrine drug, propylthiouracil. Endocrine drug, propylthiouracil. Endocrine drug, propylthiouracil. It's an anti-thyroid drug used in pregnancy. Anti-thyroid drug used in pregnancy. Miscellaneous agent, D-penicillamine. Miscellaneous agent, D-penicillamine. That is our chelating agent. D-penicillamine, chelating agent. And rare, but those drugs which can cause severe problem. Rare, but those drugs which can cause severe lupus are interferon, anti-TNF alpha. Interferon and anti-TNF alpha. Okay, these are the drugs you must remember. These are the potentially offending drugs. So if the patient is taking any one of these drugs for more than 2 months and has come to you with clinical features of SLE, you can suspect drug-induced lupus. Now time to highlight how it is different from idiopathic lupus. Now last slide, how to differentiate from idiopathic lupus. Please differentiate. Tomorrow no class. Our next class will be on Monday. Our next class is on Monday. Please take down last slide. Okay. So how, note the differences, how it is different from idiopathic SLE. So idiopathic SLE, common in female. Drug-induced lupus can affect both genders equally. Number one, drug-induced lupus can affect both genders equally. One. Number two, clinical manifestation include fever, arthritis, serositis, rash. So clinical manifestation can be similar to idiopathic SLE. Clinical manifestation can be similar to idiopathic SLE. Right, you can write clinical feature is same as idiopathic SLE. But what is different? Good news. What is different? Good news. Renal and CNS involvement are rare. Why it is important and good news? Because these are the two common killers in idiopathic SLE. And luckily, these complications are uncommon in drug-induced lupus. These are uncommon in drug-induced lupus. Moreover, all the patients have ANA. In drug-induced lupus, patients have ANA and most have got anti-histone antibody. Most have got anti-histone antibody. They have got anti-histone antibody. CBZ is carbamazepine. Is the carbamazepine. And what is important? Unlike idiopathic SLE, anti-dsDNA is absent. Complement level is normal. This is difference. Unlike idiopathic SLE, dsDNA antibody is absent. complement level is normal. Yes, you have to write this. Very much you have to write this, right? So discontinuation of the drug leads to resolution of the symptom, making the prognosis good. Leads to the resolution of symptom, making the prognosis good. So please remember, idiopathic SLE has got poor prognosis, but drug-induced SLE has got a relatively good prognosis. Because number one good point is what? The dangerous complications don't occur. Number two, treatment is only discontinuation of the offending drug. And that is why prognosis is good. That is why prognosis is good. So what I am telling you is that when you get a patient with clinical features of SLE, majority of the time it is idiopathic SLE. But you must take drug history. And the drug history, if it is more than 2 months, then you must entertain a diagnosis of drug-induced lupus. And if you suspect, you will ask for antihistone antibody. You have to ask for antihistone antibody because dsDNA is absent. Okay, that's the main difference. And if antihistone is present, you say it is drug-induced lupus and you stop the offending drug. You stop the offending drug. That's how we want to do. Steroid is not required. Right? So coming to the last point, Anna, what are our doubts here? Anna, so there is no doubt per se. Okay, so I hope this is clear now. So today we have completed the topic of SLE. Okay, today we have completed topic of SLE. In drug-induced lupus, steroids do not have to be given. Steroids do not have to be given. Okay, so today's class we will conclude here. We have completed the topic of SLE in total, idiopathic also, drug-induced lupus also. So Monday 7:30. Next we will meet Monday 7:30. Today also I will make a Facebook post. You can put your doubts there and I will solve it for you. So relevant slides, relevant notes, I will put it there so you can help correlate and recall the topic today, right? So this is where we are. So other students can leave. I am going to show the initial few slides and the slide of cutaneous manifestation to those who have missed. Okay, others can go. I'm going to show few slides with who have missed, right? So let us go to the first. Everybody, good night. Others can run away. And I'm going to take you to slide 1 just to show you. So especially the cutaneous disorder, okay, manifestation we have left, so that when the crash happened of the app. So just let me go through cutaneous disorders manifestation slide I will show for you. Right. Okay, so just this slide let me show for you. So hope today the flow was better and you could catch up, right? So let's keep it going forward. Step by step we are going, but then still we will have a thorough knowledge of rheumatology by end of next week. Okay, so for those who missed the cutaneous manifestations, for them, any other specific slide you have missed, please ask me. Okay, I am again repeating. In your eMedicos app, you can go to class images. eMedicos app, go under class images, rheumatology images, updated criteria, and all these images are already uploaded. You can go through, okay, in the eMedicos app. Right, so just have to go through. Which medicine book you have to read? You have to read our notes, and whatever topics we are teaching you in class, you can just read the same topic from Harrison, a quick read. And if you have any specific table, any specific point, you can add to our notes. Okay, only Harrison. Don't waste time on any other book. Harrison also after notes. After notes, whatever we are teaching, that much you read. And if there is anything relevant, again MCQ friendly relevant, add it to your notes. And then keep revising. Then keep revising. That's all we have to do. Okay. So this is cutaneous. The drug list I will put it on Facebook. Okay, drug list I'll put it on Facebook. Some few important slides I'll put it on Facebook today. You can take them from there. Okay, so synovitis. Notes are more than enough for final year exam. Don't write anything more than notes. Examiner may fail you. Okay, don't write more. We don't want to know too much also. Just stick to notes. More than enough. More than enough. You will get nothing less than distinction if you know notes. Nothing more needs to be done. Okay, so just go through relevant slides. I will be posting on the Facebook in a few minutes only. I'll post it up. Okay, and in that thread you can put up your doubts and we can follow them. Right? So good night everybody. Let's call it a day. Right? So good night everybody. Chalo.